Good morning, everyone. We'll try this again. I'd like to welcome our grand round speaker, Dr. Arlene Chung. She's the residency program director for the emergency medicine residency at Maimonides Medical Center. She went to NYU School of Medicine, and she completed her emergency medicine residency training at Brown University. She did a 2-year medical education fellowship at Maimonides Medical Center and obtained her Master's of Academic Medicine at the University of Southern California. And she's a leader in physician wellness and burnout. So we're really lucky to have her here today. And please join me in welcoming Dr. Arlene Chung to this.
This is all working, right? Tech's working. I have like 50,000 followers and stuff. So if I trip on something, I apologize ahead of time. Thanks for inviting me out here. It's always really nice to come over to the sister program. I was actually just down the street at Maimonides earlier this morning, and then came over to say hello to you guys and to talk to you a little bit about fear, which is a really pleasant, engaging concept. Although I hope you all learned something from today's talk. I sort of feel like I'm going to blow something up with this. This is All right, I have no financial disclosures for this talk. Perhaps the only relevant disclosure I have is that I recently discovered that I have a fear of heights. And there's probably no more humbling way to figure that out than by picking up rock climbing as a hobby, and then you're at the top of a 30-foot wall and you suddenly realize you're afraid of heights. Who's an intern here? They're intern. Oh, you're all sitting in the front. Yeah, we make ours sit in the front. This is a talk about fear, and I feel like intern year is often the time when we think about having a lot of fear. You know, you've made the transition from medical school to residency, and I remember actually making that transition and thinking as a fourth-year medical student, I knew everything, right? You ran the hospital, you knew all the back doors, and then you suddenly become an intern. You're like, oh my god, I knew nothing. And so I thought I'd share actually a story from my intern year that I still recall very vividly, even to this day. This was intern year for me. This was in August because we did a month of orientation. And my very first block, I was scheduled for Penn. And so the very first patient I ever saw as a doctor with my MD credentials was a kid. It was in the pediatric ED. And so I show up for work. I'm wearing my brand new white coat, which is completely uncomfortable and scratchy because I've never worn it before. But it's long, and so I had put it on, being like, okay, this is real. This is I'm a resident. I'm a doctor now. And so I show up for my shift. I sit down at the computer. The next patient waiting to be seen is a 6-year-old boy who's there with fever. So I put my name on him. I review the chart, and I get up and I go over to the room where he's assigned, because this is not New York. This is Providence, Rhode Island. So everyone has rooms and their doors for all the patients. So I'm walking down the hallway, and I'm standing outside of the door where this patient and his family are inside. And all of a sudden, I start to notice that my breath is coming a little quicker. I can feel my heart starting to pound in this sort of very uncomfortable place in my forehead, and I've developed this cold, clammy sweat underneath this really uncomfortable, scratchy white coat. And I peer inside the window, and there's this kid. He looks amazing, right? He looks awesome. He's sitting on the floor, looks great. Family looks really nice. And I'm having a panic attack outside of the door, because this is the very first patient that I'm ever seeing as a doctor. I'm like, oh my God, we'll just screw this up somehow. I managed to open the door. I somehow muddle through the history and physical exam. The parents are super nice. They speak English. They're very understanding. The kid looks great. And I'm having a massive panic attack, and I run out of the room once I'm done. And finally, I get to the computer, and I'm able to compose myself a little bit. And then I think, all right, so he's here with fever. Should order some TYLENOL. But what if I put in the TYLENOL order, and the nurse gives it, and then he goes into fallen and liver failure, and then they kick me out of the program, and then I'll never be a doctor again. And I think to myself, let me just ask my attending. And I brought over to my attending and said, should I give TYLENOL? And my attendant looks at me crazy. It's like, of course give the kid TYLENOL. So I gave him some TYLENOL, and he did fine, and he went home. And the rest of my shift was much less eventful after that. But I bring this point up because even to this day, I still have very vivid memories of this patient, because I had so much fear, and because it was really important for me as far as establishing my own identity as a doctor. Intern year is really scary. We did this as part of our intern orientation this past July. Hi, come in, have a seat, welcome. Sorry, I didn't mean to call you out. So we did this as part of our intern orientation this year. Anonymously, we asked the interns to sort of throw out some things that they're afraid of in the coming year. And so this was July. And you can see some of the themes that are going on here. You can see some things, some fears that they had about themselves. So losing sight of myself, not knowing what to do, not having a life outside of residency, not being the best I can be. There are certainly fears about patient care, such as not being good at procedures, killing a patient, hurting someone. And then there are fears like being alone in residency. What if I don't like it? For those of you who are curious, intern 15, I didn't know what that was. I was like, we have 16 residents. Who's intern 15? They were actually referring to this in the same way that you have the freshman 15. Apparently there's an intern 15. That was news to me. But you can see that they have a lot of fears here. And for those of you sitting in this audience who are not interns, you're probably looking at this list and thinking to yourself that a lot of these fears don't actually go away, even after you graduate from your intern year. There are a lot of things to be afraid of in emergency medicine. Emergency medicine is really hard, right? Every day we're tasked with the impossible of taking care of the sickest of the sick, no matter who comes in the door. And I would argue that we all experience fear, right? We all experience it. We all have experienced it. We all will experience it. And even though we might experience different things and be afraid of different things and sort of have different responses to it, we will all feel it in some capacity. But it's not our feeling of fear or having fear that I think is the problem. I think it's our response to it that actually drives a lot of some of the maladaptive behaviors and some of the consequences that we're starting to see running rampant in medicine. Whenever you see someone yell at a colleague, yell at a patient, you see someone who's suffering from burnout or substance abuse or depression, I would argue that some, if not a large part of that, is due to the fact that we are so afraid of sharing the fact that we are afraid that we try very hard to hide it, and it results in a lot of these maladaptive coping strategies. In fact, oftentimes we are so afraid of being afraid that not only do we hide it from other people, we hide it from ourselves. But I would argue that it's actually really, you can't just selectively block emotions. You can't just say, I refuse to feel this subset of emotions, but I'm going to feel all the other ones. It's kind of an all or nothing game. You either feel them all or you block yourself to all of them. But that's okay, right? Because I'm going to go through some steps in this talk that you can all do to hopefully open up a little bit more and learn how to have the courage to really embrace the full spectrum of human vulnerability so that we can all be a little closer and a little more empathic together. Looking at this list, probably a lot of you are feeling like maybe some of these are fears that you've experienced in the past, whether it's hurting someone, killing someone, not knowing what to do, doing the wrong thing, being sued, losing credibility, getting stuck, hating my job, not being liked, having no friends. Unfortunately, most of us went through medical training without actually ever having learned how to cope with fear, right? I would stand to reason that most of you, when you went through medical school, or if you're in medical school, probably never had a course session that was called Coping with Fear. And so in the absence of that, we develop a lot of other strategies, which are probably less helpful. But again, hopefully with some deliberate practice, we'll all be able to learn how to be a little bit stronger together. Fear is pretty complicated. I actually thought, fear is like a basic emotion, right? But it turns out fear is pretty complicated. And psychologists have spent a lot of time and a lot of research trying to break it down. And there's a number of different ways and different frameworks that they conceptualize it. One of the most sort of obvious ways, and one of the ways that we think of most often, is fear as a basic emotion, right? So this is fear in conjunction with things like happiness and sadness and surprise is one of the basic emotions. But another way of thinking about it is a social construct. So there are some psychologists who argue that the way we experience fear and the things that we're afraid of and how we respond to it are all socially driven depending on the cultures that we grow up in. Fear is seen as an adaptive survival response. So animals have fear, and that's how they know how to run away from the bear rather than towards the bear. And then finally, there's a subset of psychologists who believe that fear is related to our personality type. So for example, if you tend to be prone to, a little bit of neuroticism, a little bit of anxiety, not that anyone in medicine ever feels this way, you also might be prone to feeling more fear than other people. But for the purposes of this talk, I think it's actually helpful to think about fear in sort of three different ways, right? There are three different flavors of fear to consider. The first of these is physical fear. So physical fear is like a fear of heights. It's a fear of death, of bodily harm, of dismemberment, falling down the subway stairs, which I also have a fear of apparently. All these sort of things are physical fears. And the interesting thing about physical fear is it doesn't have to be for you, like your own body. It can actually be witnessing somebody else in pain or in distress can also translate into physical fear. The second type of fear is identity fear. This is a little bit more complex, but these are fears related to how we conceptualize ourselves, how we identify. So, for example, most of you in this audience, we all have one common identity, and that is as a doctor. But many of us also carry other identities, whether that's father, mother, friend, colleague, leader, sister, brother, whatever other identities we have, any type of action or any type of thought or any type of scenario that threatens that particular identity would fall under identity fears. These ideas of, what if I don't have what it takes to be a doctor, right? What if I'm not cut out for this job? These are all identity fears. And then lastly, we have social fears. We're all social creatures. Humans are naturally hardwired that way. And so anything in which, any situation that puts us in a position where we feel like we might be rejected or we might not belong or we might be an outcast, these are all social fears. And all three of them can be present in the same scenario. So I'm going to actually, to illustrate this, I'm going to share another story with you. This happened a little later. This was while I was still an education fellow at Maimonides, and this was my second year as a fellow. It was towards the end, sort of the end of my fellowship. I had already gotten a job for the following year, and I was really starting to come into my own as an emergency physician. I'd been practicing for about a year and a half. I was starting to feel pretty comfortable, both in the department and also with my own set of clinical skills. And so in comes this patient. We had gotten a notification about her, and she was a 30-year-old woman who was presenting with seizure, had been intubated in the field by EMS. And I was working in our resuscitation, I was at the resuscitation area, and I was like, I'll take the next one. So she comes in. EMS rolls her by, they roll her into the room, and I come in after her. And as the nurses are doing their thing, they're unpacking her onto the stretcher, hooking up to the monitor. I talk to EMS. They basically say, she was found by her husband, a grand mal seizure, no history of seizures before. He called 911, they intubated her in the field. They gave some midazolam, and she had stopped seizing by the time she came into the emergency department. Throughout the course of that brief, sort of when the husband came in, we got some additional history, and on chart review, we pretty quickly realized that she was suffering from an overdose. She had actually come into the ED 3 days prior complaining of abdominal pain, but had left without being seen. And so we surmised once her TYLENOL level came back through the roof and we discovered she was in fulminant liver failure that she had most likely overdosed on medications actually several days beforehand, and this was the natural consequence. And we figured out the diagnosis pretty early. We put her on pressors, we gave her empiric antibiotics, we had her on sedation for the vents, and she had a million drips going. I was feeling pretty good. I was like, she's a sick patient, we're resuscitating her, I have the diagnosis, this is great. Like, I am coming into my own as a physician, I know what to do, I felt very comfortable. The next step was obviously to get her definitive treatment to a liver transplant center, or at least to her ICU. Except that didn't really happen. As the night wore on, there started to be this feeling that, we had her on all these medications, we were repeating her labs, everything was actually starting to go in the wrong direction rather than the right direction. All the labs that should be going down started going up, and all the labs that should be going up started going down. I was on the phone, seems like incessantly, with the ICU, with the transplant center, and nobody wanted to take her. Our receiving facility that would have been a transplant center, they said they had no beds available. Our ICU said that she was too sick for the ICU. I didn't really understand that either, but they didn't want to take her upstairs. And here she was sort of deteriorating in front of my eyes, and I knew the diagnosis, and the thing was baffling to me, and it was totally baffling because I had the answer. I knew the diagnosis, I knew how to treat her, but she wasn't getting any better. And so I spent a lot of time in that room over the next several hours. And I remember at one point I walked in and I looked at her. I really looked at her. And this is a 30-some-year-old woman. And I went up close and I looked at her. And by this time she had gotten so many fluids. Her face was bloated. Hair was kind of stringy and stuck to her face because she was diaphoretic. And I realized that, that line separating the patient and yourself is actually not so wide, right? Because I was also in my 30s at the time. And there's some sort of transference and some physical fear at that point, but also identity fears, right? I had thought I had pretty established identity as a newly minted emergency physician, and yet, here I was sort of at the maximum of my abilities, unable to really do anything for her. And then there were the other thoughts, like, oh my gosh, like, what are people going to think? Like, they're going to think that I'm, like, not competent or not capable because this patient was very clear diagnosis and very clear treatment plan. I obviously not able to save her. So then she uses her pulse. And we initiate CPR, and she gets Ross. And then she loses her pulses again, initiates CPR, and she gets Ross. And this goes on for some time. So meanwhile, the clock is ticking, right? And we're, I don't know, about 2-3 hours after the end of my shift. Finally, the overnight attendant comes up to me and says, you just need to go home. And I realize that she's right. And I tell her, I was like, hey, listen, I have one more patient to sign out to you. And it's a really terrible sign out, but I'm sorry, I have to, you're right, I have to. And I signed her out. And I signed her out knowing that she probably wasn't going to make it. Right? At this point, I think she had gone into cardiac arrest 3 separate times. But I also knew on my own level that if I was the one to pronounce her, that I would just lose it. Right? That I would just have like a total breakdown in that room. And so I signed her out and I went home. And by the time I got home, I checked the chart. And of course, she had gone into cardiac arrest one more time, and then she had passed. And the other attending, like I think 20 minutes after I left, had pronounced her dead. And I still, again, like remember this case, think about this case. And I share it with you, one, to demonstrate that you can have multiple different types of fear that exist in a current, in one current situation, but also to demonstrate a bit of vulnerability and to show that we all have fears. And it's not that feeling fear that makes us bad doctors, it's how we choose to cope with it. All right, where does all this come from? If it's not totally clear to you by now, everybody feels fear. I don't care who you are, you feel fear, except if you're a sociopath. I don't think sociopaths feel fear, but for the most part, you can assume that fear is a pretty universal construct. And I think that all of this fear of fear, why we have so much fear of it, comes from 3 different things. It comes from having a fixed versus a growth mindset. It comes from the hidden curriculum and from imposter syndrome. Are you guys hearing a ringing? Is there like a strange ring? I'm gonna explode or something if I do that. Okay. All right. The first is a fixed versus a growth mindset. So there's this woman, Carol Dweck, who's a psychologist. She wrote a book called Mindset several years ago, back in 2006. And in it, she describes that most people, broad strokes speaking, have one of 2 different kinds of mindsets. One is a fixed mindset. And so a fixed mindset is this idea that we are born with all of the skills and abilities that we will ever have for our entire lives. So when you tell people, oh, you're so smart or you're so talented, that is reflecting a fixed mindset. It's really, actually, this book I've heard is really great for raising kids. It's like, you encourage them for a growth mindset versus a fixed mindset. The second mindset that she talks about is a growth mindset. And in contrast to a fixed mindset, in a growth mindset, there's this idea that the potential for growth is unlimited. And that none of us are born with any kind of ceiling on our abilities. And if we just apply ourselves, we can always use every opportunity to grow and to learn and to change. Unfortunately, the way that medicine is and the way that medical training is, it actually encourages the development of a fixed mindset rather than a growth mindset. Things like getting into medical school, getting a good score on step 1, matching into residency, all of these things, unfortunately, because of the way they're set up, actually encourage the promotion of a fixed mindset rather than a growth mindset. Which then leads to this. So I would argue that probably one of our biggest and most common fears is a fear of failure. There is a huge difference between the sentence on the left and the sentence on the right. One of these sentences reflects a fixed mindset, and one of them reflects a growth mindset. If you have a growth mindset, failure is simply another opportunity to learn and to grow, to change, and to become a better physician. But if you have a fixed mindset, all of a sudden failure becomes some kind of value judgment on your potential. The second thing that I think drives this fear of fear that we have, or this fear of acknowledging fear, is the hidden curriculum. So the hidden curriculum, I think, was probably best described by this guy, Frederick Hafferty, back in 1996 in this article. And he describes that there are 3 different kinds of curricula whenever we go through school and whenever we progress in our education. The first one is the formal curriculum. So that is this, right? That is Wednesday conference, that is classroom didactics, that's whiteboard teaching. It's anything that is sort of formally structured by your educators. The other type of curriculum is the informal. So this is all the teaching that happens at the bedside, one-on-one with your attendings. This is all the experiential learning that you'll get over the course of medical training and residency. And then the last one is the hidden curriculum, which is essentially everything else. The hidden curriculum is responsible for things like stereotypes in medicine. And so these are things that people have not explicitly told you about the different specialties, for example, but you sort of intrinsically know. It's the reason why when you are a third-year medical student rotating on your core courses, you know if you're on your surgery rotation, you're not going to put that stethoscope around your neck, you're going to hide it in your pocket. And if you're on peds, you better have a toy handy, and all of these sort of other things that we learn about the practice of medicine that are not explicit in either the formal or the informal curriculum, but we pick up and we learn anyway. So I'll use stereotypes in medicine, right? We all sort of understand that there are different types of people who go into different types of specialties. And again, no one ever sat down in a classroom and taught you this, but this is something that we all learn. So whether it's dermatology, or pediatrics, or anesthesiology, for those of you who are not up to date on your Disney princesses, right? Beauty and the Beast, Snow White, Sleeping Beauty, or in our case, emergency medicine. I always wanted to be a funny person, actually. I'm really glad that you're laughing. So this is one example of something that all of us have learned in the hidden curriculum. But I think probably one of the most powerful lessons that we've all incorporated, whether we're aware of it or not, is that doctors don't show weakness. And this is one of the probably most powerful lessons that we learn throughout our medical training, is that doctors don't show weakness. And so the problem with incorporating this particular lesson is that all of a sudden when you feel weak or inadequate or like you don't know something or that things aren't going how you expected, you can't let other people know because doctors don't show weakness. This is the reason, this lesson is the reason why you will see residents around the ED hooked up to IV poles and with nebulizer masks who are working with fevers of 101. This is why no one ever calls out sick. This is responsible for, actually I saw this on Twitter kind of recently, this is responsible for a resident who had tweeted out to the world, is it okay to cry after the death of my first patient? I mean, of course it's okay to cry, but the reason she's even questioning this is because of the lessons that we learned through the hidden curriculum. Doctors don't show weakness, and I would argue that this is the second thing that contributes to our fear of fear. The third thing is imposter syndrome. So imposter syndrome is pretty new. It was first described by these ladies, Pauline Rose Clance and Suzanne Eames in 1978. And essentially what it is this idea that you are not qualified to be doing the things that you're doing or to be in the position that you're in, and you're simultaneously terrified that somebody is going to find out. This feeling of being fraudulent, and it's this idea that it's this idea that you have difficulty incorporating your own personal successes. It's called imposter syndrome, imposter phenomenon, variously in different literature, but essentially it's the same concept. Although they first described it in women in this particular study, subsequent research has actually demonstrated that imposter syndrome is common in men as well. It tends to be much more common during times of change. So, for example, graduating from medical school, getting your first job as an attendant, moving to a new city, getting married, getting divorced, having a kid, all of these sort of transition phases are times when we're most susceptible to imposter syndrome. And in fact, 70% of all people at some point in their lives will have feelings that they don't belong, or that they're not qualified, or that they're not good enough to be wherever they are, but somehow they're just getting by, but are still afraid that somebody might find out. I thought you were going to come keep me company. Like a dual talk? Okay. I bring this study up, actually, it's interesting. There's actually very few studies that have been done in the medical literature on imposter syndrome. This one is actually not done in the medical literature, it's done in a university setting. But I bring it up because I think it probably highlights one of the biggest consequences of having imposter syndrome. In this study, it was a qualitative analysis, and what they did was they interviewed students and then faculty at a university, and they correlated their interviews with whether or not they scored high or low on one of the imposter syndrome scales. And what they discovered was that people who had high levels of imposter syndrome had a tendency to actually turn down opportunities in which they might be put in a leadership role, or they might be elevated to a position where other people could potentially see them fail. And what's really unfortunate is that even though these opportunities might have led them to greater career fulfillment in the long run, they were so scared of being found out as a fraud that they actually turned them down and they took either lower paying jobs or less sort of productive job opportunities because they were afraid that people would view them as unqualified or not able to be, that they weren't actually who they said they were. Like fear, we all have imposter syndrome. All right. So what happens when we have all this fear? So just to recap, I think where all this comes from, like why we're so afraid of being afraid, right? It comes from three things. It comes from having a fixed versus a growth mindset, the hidden curriculum, and imposter syndrome. So fine. But what happens when we have all this fear? What's the consequence? And I want to come back to this one, because I think for most of us, this is the crux of it, fear of failure. When we're afraid, I think the natural tendency is to protect ourselves, right? So metaphorically speaking, the heart is sort of our open center. It's the pathway to all of our emotions and our vulnerabilities. And whenever we feel scared or when we feel threatened, our first inclination is to cover it up and to protect it. So we put on armor. Brene Brown is she's a researcher who does a lot of work on shame and vulnerability. She's got some great TED Talks out there, fabulous books. If you have not read her books, I would highly recommend them. They're all great. But she talks a lot about this concept of vulnerability and consequently armor. And so armor, again, metaphorically speaking, is something that we put on to protect ourselves. And so there are multiple different ways of doing it. But as I mentioned before, armor is armor, right? And so if you're putting it on to block yourself from feeling fear, you're also blocking yourself from feeling joy and professional fulfillment and triumph when you save that person's life. You're blocking yourself to all of these other wonderful emotions that really make the practice of emergency medicine worth it. Some of these kinds of armor are probably more familiar than others. I think perfectionism is one that we can all identify with. Perfectionism is interesting, right? It's this idea that if I can just be perfect and look perfect and speak perfectly and get the perfect score on the exam, then I am somehow protected from failure. But as we all know, that's a fallacy, right? And perfectionism is this self-fulfilling cycle where it's unobtainable and therefore eventually actually leads to even more shame and more guilt. We all know, right? The end of a long shift, you go home, you open up that bag of Tostitos with lime, you sit on the couch, you binge watch Stranger Things, right? We've all been there. Don't do that. And that's okay, right? It's sort of it's not necessarily a maladaptive response in itself, but the problem is when numbing becomes habitual and therefore becomes addictive, that's when it becomes problematic. Being right and crushed or being crushed are related to each other. It's this idea that we sometimes have that medicine is a zero-sum game and there are winners and there are losers and you better not be on the losing side, right? This is the reason why you will see fights between different consulting services, why you will see people get angry at other staff and other patients, because I don't want to be wrong, because I have to be right. And this is one way that we cope with it. And we put on armor because if we're wrong, we're losers, and therefore people will think we're inadequate, and gosh, they'll find out all of our fears and our insecurities. Cynicism and sarcasm actually aren't even really armor, they just represent a failure to engage in the first place. The Greek root of sarcasm is actually to tear flesh, if that gives you some context into how damaging that can be. So we all do it, right? We're also, when we have all of these fears, if we haven't learned how to sort of productively cope with them, our natural inclination is to put on armor to protect ourselves. But not only are we blocking ourselves from feeling fear, we block ourselves from feeling joy. And that has some downstream consequences. I think burnout is one of the biggest ones. Being well is not simply the absence of burnout. I think there's been a lot of emphasis on wellness and burnout recently, but I think just because you block yourself from feeling all the negative emotions does not mean that you automatically get to experience all the positive ones. So just because you're not burned out doesn't necessarily mean that you're not experiencing joy or engagement or loving your job or you're super excited to go in the next day. I bring this paper up, it's getting a little bit dated now, but the reason is it's because it caused a lot of stir in the emergency medicine community. They surveyed about 30,000 physicians of all different specialties across the U.S. They gave them all the Mad Burnout survey, and they found in general, they found an average burnout rate of about 46%. And that was all specialties surveyed. The range was anywhere from 30% to 70%. And guess who was at the very top? Us, right? Emergency medicine. And we actually won by a landslide in this paper. And it was one of the first large-scale studies that was done on burnout prevalence in the U.S. and physicians. And so it caused a big stir in our community, in the emergency medicine community. And I would argue that part of the reason it was so high in medicine, in emergency medicine, is that emergency medicine is really scary, right? There's so many things to be scared of. We see people, who come in who are critically ill. You have to make all these decisions on your feet, limited information. In some ways, there's a lot to be afraid of, and so perhaps it's not so surprising that burnout rates were so high. But burnout has downstream consequences, right? Not just for us, right? Certainly it's associated with depression and suicidality and substance abuse and anxiety. It also has consequences for our patients too. People who have high levels of burnout report lack of empathy, an increase in reported and perceived medical errors, and probably most impactfully for our patients, a desire to leave the field. Let me share another story with you. This one is not my story. It's someone else's story. I'm going to call her Katie, although that's not her real name. And I'm going to demonstrate what the difference is between putting on armor versus being brave enough to take it off. And so actually the first time I heard this story was a couple years ago. I think it was something like 2015, 2014. It was at one of our first Airway Stories events, which some of you may have been to, right? So there are these series of storytelling events that we host in the city where we get emergency physicians from all around to come in and to share their stories. And she actually told this at one of the first Airway events. And this was a story of her as a resident. It was her intern year. And she was on her trauma rotation. It was a busy night. She was tired. It was near the end of her shift. And she had a needle stick. Except that the patient that she had been suturing, she actually got herself with a suture needle, was positive for hepatitis C. So of course she was concerned. I mean, everyone's like, this happens all the time. Just go to employee health, just do all the things, like take a patch, you'll be fine. And she did all those things. Of course, all the lab work demonstrated the patient was confirmed positive for hepatitis C. And several weeks later, her own blood work also confirmed that she had hepatitis C, that she had contracted it from this patient. And this happened very early in the residency training. And of course, she was devastated. She told nobody, did not tell a single soul that this had happened to her, because what's going to happen when people find out? Is she going to graduate? Is she going to be able to practice medicine? Are patients going to want to interact with her? Are people going to want to be her friend? Is she going to be able to have a relationship? Who's going to want to be with somebody who has hepatitis C? Is she going to die? Right? All these physical fears, identity fears, social fears. She was so afraid that in order to protect herself, she put on all of this armor and didn't tell a single soul. Naturally, what everybody else saw was somebody who was angry, burned out, got into a ton of fights with consultants, didn't do very well in residency, but they didn't know. Right? And so you can see she had all the signs of burnout, depression, anxiety, and she graduated. And she went on. And actually, over time, she did take an experimental therapy, and years later, she cleared. She cleared the virus, thankfully. And obviously, this was a big sigh of relief, and she never actually shared any of this until probably 6 months after she had gotten her last test result confirming that she was in the clear, when there was a young EMT had come in, all with a needle stick, from a hepatitis C positive patient. And she chose at that moment, when she was taking care of that one patient, to tell her story and to share that with him. And while obviously in the moment, his case was still uncertain, it made him feel so much better that somebody else knew exactly what he was going through and exactly how he was feeling and all of the fears that he had going forward, because they were all the same fears that she had had. But perhaps most importantly, not only did it make the patient that she was taking care of feel better, it made her feel better. And she took off all that armor. So what next? Courage and fear, bravery and fear, are not mutually exclusive. And I would actually argue that a lot of times they coexist at the same time. It takes a lot of courage to face your fears. It takes a lot of courage and bravery in order to acknowledge when you don't know something, when you're unsure, when you have the wrong answer. It takes a ton of courage to do that. Bravery is the quality or state of having the mental or moral strength to knowingly face fear, danger, or difficulty. It's not weakness to admit that you have fear. It's actually a demonstration of strength. I love this quote. This is actually a quote from Teddy Roosevelt, but Brene Brown brings it up in one of her books, Daring Greatly. And Teddy Roosevelt once upon a time said, "It is not the critic who counts, not the man who points out how the strong man stumbles, or where the doer of deeds could have done them better. The credit belongs to the man in the arena whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, who at the best knows in the end the triumph of high achievement, and who at the worst, if he fails or she fails, at least he or she fails while daring greatly." This is Maimonides, but this is the arena. This is our arena. Every day we are tasked with the impossible. We are asked to bring back the dead into the land of the living. We are asked to mend the broken, to heal the sick, to cure all ailments. We're asked to put on band-aids on cuts. We're asked to put in chest tubes and resuscitate the unresuscitatable. It's really freaking hard. The practice of emergency medicine is really hard, but it is also tremendously amazing and rewarding. I mean, how many people get to say when they go to work, "Oh, I saved someone's life today," and mean it? We get to do that. And all of these triumphs and all of these successes, we should be able to experience them and embrace them fully. And in order to do that, we have to be willing to embrace the entire spectrum of human emotion and not be quite so afraid to embrace some of the negative ones, like being afraid. The good news is that courage is not a fixed trait. And so if you're sitting there thinking to yourself, "Oh gosh, I don't know if I have the balls or the ovaries to really do that," courage is not a fixed trait, and it is a skill that you can work on and actually through deliberate practice every day, every shift, every patient, grow a little bit stronger every day. The first is to be prepared. Be prepared. You are going to be scared. You are going to feel fear. That is 100% certainty, whether you've committed to emergency medicine or committed to an academic career or community career, or if you'll never work single coverage or you'll never work nights, regardless, you will feel fear and you will face scary situations at some point in the future, if not in the next shift. And so be prepared. So one of my friends is a performance psychologist. His name is Jason Brooks, and he does a lot of work with preparation and visualization. It's pretty interesting. He has a lot of theories on how we can be best prepared for these situations. And one of the techniques that works for athletes, and actually certainly works for us, is visualization. So think about those cases that scare you. Is it the newborn arrest? Is it the critically ill trauma? Is it the undifferentiated patient? Is it the difficult airway or the failed airway? Think about those situations that scare you and prepare for them. Visualize what you would do. Imagine the heat of the moment in the room. Imagine the supplies. Walk through the steps of the procedure. All those visualization techniques, they work for athletes. They should certainly work for us. Other things that you can do to prepare. In those moments after you get the notification that you have a critically ill patient coming into the room, there's a technique that's actually really great to use on shift. It's called box breathing. So as you're standing there in the resuscitation bay and you're assigning roles to different people and you're making sure the airway parts stop and that you've got the thoracotomy kit and arm's distance, you can also engage in sort of managing your own stress response by breathing in for 2 seconds, holding for 2 seconds, breathing out for 2 seconds, holding for 2 seconds. And you can stand there at the foot of the bed before the patient has arrived and breathe for a few moments. Nobody has to know. And get control of your own heart rate and your own emotions so you're that much sharper and you're that much prepared for when the patient hits the door. The next step is to be human. It is definitely okay to cry after the death of your first patient. It is okay to embrace the full spectrum of human emotion. We are not some emergency medicine automaton robots that are just there to throw in chest tubes, right? It is okay to feel joy, to feel sadness, to joke around with your patients, to hold their hands as they go through rough moments. I think feeling all those feelings. It's totally natural. It's part of being human, and it's how we can demonstrate our own vulnerabilities. So be vulnerable. This is how we change culture. I would argue that this is how we change culture. It takes a lot of courage to open your heart and to admit your weaknesses, to admit that you don't know something. I was lucky enough to attend a rebellion in the conference this past June down in Texas, and I heard Swami give his talk on the 3 most powerful words in medicine. I don't know. And the reason these words are so powerful is because they are a very frank demonstration of vulnerability. I think the day that you open up and admit your own fears, your own weaknesses, is the day that some medical student who's listening to you learns something different about what it means to be a doctor. There's a lot of ways you can do this, formal and informal. I would argue that actually the best way to practice vulnerability is through storytelling. It doesn't have to be at some formal airway event. Storytelling can be incorporated in big ways or small ways, whether it's in a residency program or not in a residency program. Simply getting a group of people together who have a common shared experience and who are willing to share that with each other creates a safe space for everyone to be a little bit more vulnerable and to share those emotions with each other. Be empathic. Medicine is not a zero-sum game, right? Be there for each other, support each other. It's hard, right? But we're a lot stronger if we can get through it together. Ways to do this, again, peer support programs, big SIP, little SIP programs, mentorship families, retreats, get-togethers, all these different mechanisms that we have to share our spaces and really demonstrate our support for each other will help us get through it and we'll all be stronger together. All right, so what next? So in closing, just to summarize, the practice of emergency medicine is really scary. It's amazing, but it's really scary. And unfortunately, most of us have never really learned how to cope with all that fear, all those scary things. And so our tendency is to put on armor to protect ourselves. But lugging around all of that baggage has some of its own consequences, such as burnout, depression, substance abuse, suicidality. I would actually argue that if you can take a moment to put that armor aside and open yourselves up to being vulnerable, it actually leads to a much more fulfilling practice of medicine and emergency medicine in particular. Ways to do this: be prepared, be human, remember to be human, be vulnerable, and be empathic. So I would encourage you all to, on your next shift, whether it's in a few hours, tomorrow, next week, not to fear fear, but to embrace it. Thanks. I hope you liked it. I'm happy to take any questions or any comments even. If anyone else would like to share their own stories.
I'm really happy that you brought up the point about one of the difficulties, especially in residency and medical schools, how we don't share our own struggles. And I think that that's something that we can do as a group better, and as a program better, and to get residents and medical students to share their failures. When someone doesn't pass a block, connecting with people who haven't passed blocks together and showing that you're not the only person who didn't pass a block. Or when somebody fails an exam or does poorly on an exam, sharing what's the process. Because a lot of people are so afraid of what the consequences are of failure that they don't even know what the next steps are. They don't know that the faculty, the program directors are there to support them through these situations. And so people avoid, talking about it. I think everyone has something to learn. It takes away some of that anxiety of failure too. If you know that you missed in med school, let's say you failed a block and you're going to get a repeat and you're going to take the test again, it's not going to show up on your transcript. That makes the fear of failure a little less scary. And so I really appreciate you bringing that up and encouraging people to share their failures with each other as much as our successes, because we only tend to share this. Thank you.
I think your point about I don't know is very well taken. It's so true, and we're so hesitant to say that. Probably the next 3 most important words is we don't know. Because a lot of times the evidence just doesn't have an answer. And that's another thing that sometimes we're just afraid to share with patients.
What do you think are some of the things that you've been able to do to have you been able to do?
Like for myself, or
Yeah.
I think one of the things that really helped me a lot was when I realized reading Brene Brown. That was very helpful. I really recommend any of her books. But I think for me, realizing that I wanted to be the person that I wish I had known as a medical student, I think was the thing that actually helped a lot. Regardless of whether or not I'm actually working with a medical student at that time, but trying to change that culture, even though you're one person, but one person leads to another act that maybe somebody else sees that leads to another act going forward. I think I had a lot of anxiety and a lot of sort of stuff swirling around in my own head going through medical school and residency, and so I've learned to be more open about that. But I think it would have been nice to have heard some of this stuff then and realize that I didn't have to go through all of that by myself.
So, thank you. This is such an incredible and important talk. Last year, for my first fellowship, I was in shock trauma in the trauma unit. And one of the things that I think they've done really well, especially so many people, gunshot, cardiac arrest coming in, everyone is afraid, is what you said about being human and with the team around you, forming this sort of community where you're joking before, as everyone is preparing, you're kind of settling your nerves through the humor, which is a healthy coping mechanism, and you know each other, so in that collective fear, you support each other, and that is, I felt, to be so helpful in dissipating what you can take on your own.
It's amazing what happens when you actually talk to somebody about it. I had this moment, this was when I was working at Elmhurst, and we had just had some kind of M&M on suprapubic catheters, and I think 3 days, and then so there was some comment during the M&M where it was like, every emergency physician should feel totally comfortable placing a suprapubic catheter, something like that. And so I was on shift 3 days later, and there was this patient who had some complicated surgical thing and came into urinary retention. And I was working the triage shift, and I was like, oh God. So I walk out of triage, and I find one of the senior attendings, and I was like, Danny, so I know we just had this M&M, I was like, we just had this patient who came in. I was like, can you help me? I was like, I don't know what to do. And he was like, I don't know how to place one of those either. Cardiology. But it's amazing sometimes, right? What happens when you actually admit those things to people. The patient was fine.